Nankri Nangi, everyone. Nanawai Paul Worley, Napi Puteri Maori Pomerokonk, and Natajeri Rui. Welcome, Nornyandu, to this race grand round. My name is Paul Worley. I'm the Executive Director for Clinical Innovation here at the Riverland Mallee Coorong Local Health Network. And these grand rounds are an opportunity for us to learn from the best around the world and put that learning into practice through collaborative quality improvement and research. Today we are very fortunate to have a report on research that's been conducted in the RMC footprint, as well as collaborating with other footprints. When we commenced the Academy, one of the first people to reach out to us to look at some collaborative research was Dr. Geraint Rogers and his team at SAHMRI, because they were looking to see what they could do as researchers to decrease the burden of COVID on nursing homes and the residents of those nursing homes, and whether there might be a very simple opportunity to intervene and improve things. So we decided together that this was something that was worthwhile, and our residents agreed that it was worthwhile, our staff agreed that it was worthwhile, and it's taken a long time to get through all of this, but I'll hand over to Dr. Rogers and let him talk to you about this really landmark study on ultraviolet light and residential aged care. Welcome, Geraint.
Thanks, Paul. It's a wonderful opportunity to talk to you about this work. Hopefully it's going to be of interest. But as you said, I think it's an excellent example of where the LHN has partnered with other groups and made a really impactful contribution. So hopefully it can be a template for future research. Can I just check that you can see the slides at the moment?
Yes, perfect.
Okay. So, okay, I've just got to work out how you progress them in Teams. Teams is the gift that keeps giving. Okay, I don't seem to be able to progress my slides. Just one second. Okay, maybe I can do it manually. Okay, so you can see the second slide, can you?
Yes, that's working.
Yes. Okay. So look, I think we all know that viral respiratory infections are annoying and frustrating and unpleasant. But in the context of aged care, they can be deadly. This is some data from a colleague of mine at the Registry of Senior Australians, where they calculated that about 12% of aged care residents would be hospitalised at least once in a year for a low respiratory viral infection. The associated mortality is high. The associated readmittance is high, and if anything, we are seeing the rate of hospitalisation increase. I think this is something that traditionally we've perhaps put down to being an inevitability of aging and becoming more frail. But in recent years, we've started to think whether, in fact, it is something that has to be tolerated, or perhaps it's something we can prevent and manage better. And a lot of that came into focus, I think, because of the pandemic. Okay, it's still not progressing. Just one second. Okay, there we are. So obviously, if you cast your minds back to late 2019 or beginning of 2020, which I know seems a very long time ago now, we were getting these reports of a mysterious pneumonia in China. I remarked to my PhD student at the time, who happened to also be an ID consultant, that it must be a slow news cycle, and she said, "No, this is going to be a big deal." And of course, she was right, which is why you should always listen to your PhD students. And we started to see COVID cases outside of China, and it spread around the world and slowly kind of rumbled towards Australia. And one of the places that we saw particularly badly hit in that initial period was Italy. And one of the things that I took from those outbreaks in Italy was that it appeared to be particularly devastating in the context of aged care scenarios. So this was one of the first outbreaks. This was in a place called Cremona, which is about an hour's drive outside Milan. And there they had one of the first cases in aged care where they had 100 deaths out of 400 residents. So really quite horrific outcomes. And even in seniors living in the community, they were seeing very high rates of mortality. And this isn't always the case with respiratory pandemics. They don't always hit older individuals quite this hard. So it was clear that when it got to Australia, this was going to be a particular issue that we were going to have to deal with. When it did get to Australia, sorry, just one second. I'm not able to. There we are. When it did get to Australia, although not South Australia, we did see a very large number of outbreaks in aged care. These are just some selected examples which I pulled out of the data. These are all in Victoria, but I think what you can see and what I've highlighted here is that these had very high rates of mortality, so up towards 50% in many cases in this pre-vaccine period. The other thing that was notable was that there was quite a strange epidemiology involved. So people who were returning from overseas were being placed into quarantine care in hotels, and there were a number of cases where infections were escaping outside of the quarantined area. And initially that was put down to lax security or the absence of stringent protocols. But the more it happened and the more the protocols was tightened, the more it suggested something else was going on. This is distinguished Professor Lydia Morawska, who's a colleague of mine up at QUT in Queensland. She's a global expert in airborne respiratory viral transmission, and she actually wrote an open letter to the WHO, who she's an advisor to, and also this invited commentary in CID at the time, saying, you know, we're missing something here. We really have to start thinking about airborne transmission. So just a very quick reminder for anybody who is a bit sketchy on this. When you cough or speak or shout or sing or whatever, you produce particles, you produce droplets of liquid. And the majority of these are over sort of 5 microns. They're quite large. They settle out of the air quickly, and they're only transmitted over a short distance. And all of the infection control practices that we had at the start of the pandemic related to cough droplets, whether that's staying more than 2 meters apart or wearing a mask or washing your hands or cleaning surfaces, they all relate to cough droplets. But in addition, you also produce much smaller droplets, less than 5 microns, and they stay in the air column for much, much longer and can travel across much greater distances. And importantly, none of the containment measures that we had at the time were effective in preventing airborne transmission. And so based on the impact that we were seeing the pandemic having in aged care, and based on the knowledge that this could be an important contributor to transmission, we set out to undertake a study. This was funded by the MRFF, which is a federal funding initiative, and they had a special call for related to COVID-19 at the time, and we were able to secure $1.4 million from them to do this work over 3 years. So we started to think about aged care and what we might be able to do to reduce transmission rates, and we needed to do it quickly, and we needed to do it cheaply, and we needed to do it with a minimum of disruption. And essentially there were 3 options that we could look at. The first is increasing air exchange. So if you have airborne particles and you sluice air through these facilities, you can just reduce the burden, you can reduce the concentration of those particles in the air. The problem is that we've known about this for a very long time. It's been resisted for a very long time, mainly because of the costs involved, the heating and cooling costs. And we can't just turn on a dime and do this in care facilities, because that's not how their HVAC systems are set up. The second option was to physically remove particles from the air, so HEPA filtration. And that is an approach that was used in a number of settings. The problem is you need to integrate it into your HVAC systems, you need to maintain it, you need to clean the filters and so on. And it wasn't very practical when a lot of these facilities were already in lockdown. The third option, which is the one that we actually settled on, was to use germicidal UVC. So when UVC light hits nucleic acids, it damages them. It causes thymine dimers to form, and it, obviously we all know in Australia. I'm relatively new to Australia, but the UVC will damage the DNA in your skin cells, which is why you can develop melanoma. But it also damages the DNA or RNA in viral particles or bacteria. And what happens is if you get enough of this damage, they can't replicate, and the infectious agents are made non-viable. We've known about this for a while. It's used in places like TB hospitals to reduce transmission. And we also know that under laboratory conditions, it's effective against respiratory viruses, including coronaviruses. We could readily fit it into aged care, but what we were lacking was a demonstration of effectiveness in a real world setting. So that's what we set out to acquire. We had to move quickly, so we had to use established technologies. There were 3 modalities of this UVC appliance that we could use. The first is an in-duct system that actually sits within the HVAC ducting. It's quite disruptive to fit that in an aged care, a working aged care environment without having all sorts of engineers and people stamping about. The other 2 could be readily retrofitted to walls, though. The first is a fan-driven device where air is sucked in, exposed to UVC, and then blown out again, which is this one at the bottom. And the other one is a ceiling. It's mounted to the wall close to the ceiling. It sends out a horizontal beam of UVC. And then as viral particles and droplets pass through that beam of light under natural air movement, they become non-viable. Our trial design was really just to identify in different aged care settings 2 comparable zones. And we would fit these GUV devices in both zones. And then we would have one active for 6 weeks whilst the other was inactive. And then we'd have a washout, and then we would switch over. And that meant that the infection control practices, the resident populations, outbreaks, everything was kept consistent between that comparison. The outcome was really the number of symptomatic respiratory viral infections. Obviously, diagnostic services were under a huge amount of strain during the pandemic. And for older residents, both are important, both pandemic COVID-19 infections, but also things like RSV and flu. And so we didn't attempt to really distinguish between those. We used a clinical definition that relates to influenza-like infections, which basically is, you can have 3 respiratory symptoms out of, you have to have a sudden onset of symptoms. You have to have 1 of 3 respiratory symptoms. So that's worsening cough, sore throat, and shortness of breath, and at least 1 of 4 systemic symptoms. So fever, headache, malaise, or myalgia. This slide appears to have corrupted. I'm going to blame Teams, apologies. But essentially what we did, if you can ignore what's at the back there, we recruited 4 facilities, one of which was in the LHN. And these facilities were selected in part because they were willing to be involved, but also because they represented different funding structures, different populations, different designs, different ages of facilities. And if we are to roll out this as an intervention widely, then obviously we need that flexibility. So this is a schematic just of one facility. The only reason for putting this up is to show that we distributed GUV devices across the facility. We stuck to common areas. So we thought it would be too disruptive and expensive to install GUV devices in all of the residents' rooms. And we were particularly concerned about transmission events in shared spaces when people are having their meals or passing each other in the corridor or whatever it might be. So we stuck to common areas. And these are just some pictures of the devices once they were installed. This is the ceiling level device that puts out a beam of light. You can see that kind of blue glow. But I think you'd probably agree that they're all relatively inobtrusive, and most people think there's a split HVAC system or something. So we we didn't experience any particular concerns from residents. Obviously, you plan your trial as well as you can, and then things always go wrong. The first thing that was a challenge was that the state closed its borders, which I think was terrific for the population of South Australia, but a bit of a headache if you're doing a clinical trial, because we didn't have any cases. The other thing that was a spanner in the works was, I don't know if you remember, but the Evergreen was a boat going through the Suez Canal and performed a poorly executed three-point turn. And all of the devices that we were installing were bought from Italy, so they were on a boat that was behind the Evergreen. So that was quite a high stress situation, although they arrived eventually. But what we had to do was, rather than having what we initially planned, which was 2 cycles in winter periods, because we were delayed and had to start late, we said, okay, we'll just run contiguous cycles. So devices on in one place and off in the other, then a washout, then crossover, then run again, then a washout. And we just ran that continuously in all of the settings. So these bars just represent each setting and continuous cycles of the intervention. As Paul mentioned, we've now finished the study and we're publishing it in JAMA Internal Medicine. It's embargoed, so I'm going to show you the results, but they won't actually be in press until about a month from now. So this was interesting. This was the distribution of respiratory viral infections in South Australia during the trial period. And it's probably a little bit small for you to see, but essentially we had a mixed bag of common seasonal respiratory viruses, RSV, adenovirus, influenza, and so on. But we also had COVID-19. And we didn't think this was a disadvantage. What we're ultimately trying to get towards is better pandemic preparedness for the future, but also a mechanism by which we can reduce the seasonal burden of respiratory infections on old people in residential care. So this plot shows infections in the control zones or in the intervention on a regular basis. And if you look at this, you'd say, well, it doesn't look like you found anything very interesting, because it seems to be just a random variation. And in fact, our primary analysis was based on treating each intervention period as being independent. And if you do that, you don't see a significant effect. It's likely that this is because the number of respiratory infections within any period was relatively low. So it's very difficult to get a significant difference between intervention and control. But as a happy accident, because we'd had to run the intervention again and again and again and again, what we could do is look at the cumulative effect on cases throughout the study. And that's where we see something really interesting. So these plots, just to orientate you, the blue line is the control. The orange colored line is where we have an intervention. And what we're looking at here is the number of cases of symptomatic respiratory viral infection. And as you can see, they diverge. Here, there's a bit of an inversion. So the cases in the intervention arm were higher. That's quite interesting, because what's happening there is an outbreak in an MSU, a memory support unit. And so a lot of facilities have these specialist units to care for people with quite advanced cognitive decline, dementia. And it's very, very difficult to control that, because you can't, ask them to wear PPE, you can't ask them to stay in their rooms and so on. And if we exclude cases in the MSU, you can see that the separation of the intervention and control is even more pronounced. And if we look at that, we looked at an autoregressive time series analysis, we see that the cumulative difference in the number of cases is actually very significant. And it stays significant regardless of whether MSU cases are involved. And it also stays significant if we account for viral incubation periods. So you might contract a viral infection at the end of an intervention period, but it might only become symptomatic during the washout, or equally, you might have an infection acquired during washout that becomes symptomatic in the intervention period. So if we apply a 3-day wobble, it still stays significant. So this was very exciting for us. If we look at what this translates to, what this interventional effect translates to, it's around a 12% reduction in cases of infection. Now, this was our first attempt to do this. We didn't know what the appropriate way to deploy these units were. We didn't know how many units we needed. We didn't know if they would have any effect at all. So a 12% reduction was really, I was very, very pleased indeed about that. If we model what that reduction would look like, it's around 92 ARIs per 1,000 residents, which might not seem like a huge amount, but if you consider the amount of hospitalization and the amount of mortality associated with these infections in aged care, it's very substantial indeed. And so we believe that if we were to refine this and optimize it and then deploy it more widely, it would have a very substantial benefit, not just if we have another pandemic or the ongoing effects of COVID-19, but seasonal viral outbreaks, influenza season, RSV season, and so on. The final takeaway, which I mentioned at the beginning, is that I think this is an excellent example of a collaboration with RMC, LHN, and institutes more widely. Obviously, I'm based in Adelaide. That's where I'm talking to you from, and I think we can often, as researchers, look in our immediate surroundings for partners and collaborators, which both misses some of the really valuable input from places more widely, and means that we don't have input that ensures that any intervention we develop is effective and appropriate for people who aren't necessarily living in metropolitan sites. So I think I've spoken for 20 minutes. I just would like to acknowledge the people who contributed to this study, not least Paul and also Shelley Humphreys, who was pivotal in providing data from the LHN. And in addition to these researchers and clinicians, obviously I'd like to acknowledge the essential contribution of residents of these facilities, their families, and the staff that were looking after them, because obviously we couldn't have done any of this work without their support. Very, very happy to answer any questions you might have.
Thanks, Geraint. That was a fascinating walk through the COVID experience that we've all been through. Reminded us of some of the events, but also some outstanding results. What do you think would have been the impact if this had been available in all nursing homes across the country? What sort of change in outcomes do you think we would have seen? You raised those very worrying outcomes, where up to 50% of residents died because of COVID. Do you have any idea of how this could be translated nationally?
Yeah, I think one of the benefits is not that we have 12% less cases, but that transmission is slowed. So this almost is it's a carbon rod in a nuclear reactor. It just slows things down. And where we saw those very high levels of mortality, what was typically happening was that transmission was occurring through facilities before anybody could respond, quarantine people. There was no time to prevent the spread. And so before you knew it, you had very high rates of infection and, as a consequence, high rates of mortality. If we can just dial back rates of transmission a little bit, it gives us more time to identify what's happening and to intervene and to separate and to try to control the situation. And so my hope would be that if we were to introduce this widely, it would act synergistically with the existing infection control measures that we have, and would just provide more time and more opportunity to protect people.
Yeah, which I guess one of the outcomes of less infections is less hospitalizations, and in the city at least, that means less ramping, which
Yeah,
is obviously a
absolutely.
significant priority at the moment.
Yeah, and that's a good point. And I think that it might sound a little bit cynical, but there's also the impact of outbreaks in aged care on the wider population. I mean, we know that anyone who's got kids will know that a lot of infectious outbreaks come from school and childcare. That's where those are the incubators for them. And there's also there's also the potential for outbreaks in aged care, both to seed infections into the community more widely, but as you say, also utilize a huge amount of the resources we have in primary and tertiary care, as well as the distress and the anxiety for the families and the people undergoing these infections, even where the outcome is good. So yeah, I think looking at it from all of those in relation to all of those benefits makes it an attractive option, and it's not hugely expensive, and it wasn't challenging to retrofit. So we are now wondering about other environments. So we have just across the road, we have an integrated cancer care centre where people are going, many of whom are immunosuppressed. Can we improve their outcomes? Daycare, schools, all sorts of contexts, arguably would benefit from this kind of technology, I think. And
Well,
I have no vested interest in this technology. It's just
yeah,
I don't have shares in it or anything.
I was just going to say that, but it would seem that, at the least, dialysis units and chemo infusion units would be obvious places that you would want to have this sort of technology again as
Absolutely,
just as a rate limiter,
absolutely.
if nothing else.
And so,
yeah, go ahead.
I was going to say the costs of doing this pale into insignificance when you look at the costs just in terms of healthcare. Should you get someone who's immunosuppressed getting a respiratory infection, for example? And the other thing is, it's not just respiratory viruses. It's also airborne bacterial transmission. It's also gastrointestinal viruses that can be spread. I know it's not nice to think about, through airborne particles and so on. So, we focused on respiratory infections because it was the pandemic, but I think there are other clinical situations in which this might be beneficial.
And the approximate cost for each of these units?
The units were, depending on the modalities, they were in the low three figures. So to completely kit out one of the big facilities here in the city, I haven't got the numbers to hand, but maybe it would have been $30,000, $40,000, $50,000, which is not peanuts. But those appliances are still in place and are still running, and they have no moving parts apart from the fan-driven one, so they can stay there forever. And in fact, all of the participating centres said, "No, can we hold on to them? We'll hold on to them." So there is an initial outlay to buy the kit, but the length of time that it can provide benefit for is very long, and the running costs are very low. It doesn't require much energy to activate these UV lights, so once it's installed, it doesn't cost much.
Yeah, thank you for that. The other thing that I see some relevance in the research that you've undertaken is the method of analysis, moving from just looking at month by month analysis to cumulative analysis. It's one of the issues in aged care more generally is that adverse events that occur there tend to occur in very small numbers in any one particular month. But it's that trend that's probably more relevant in terms of decision making and wanting to find where to put our effort into quality improvement. So
Absolutely.
yeah, thanks for that example of how to actually analyse data more appropriately for this environment.
And sorry, just on that, that's a very good point, because the other thing about that is that if you want to look at something that takes a while to have an effect, the aged care population doesn't have a rate of turnover, which means that if you focus on individuals, you have a limited time frame. Whereas if you focus on it as a population, you can do much more, much longer studies.
Yeah, no, some wonderful lessons and a very profound collaboration. Thank you for presenting this data back to us so that we now have the opportunity to see how do we apply what's been learnt in our own backyard. Thank you, Geraint, and all the best with the further studies in how this technology can help other environments. Congratulations.
Thanks, Paul. And just before I go, I'd just like to again say thank you, because we couldn't have done this work without your partnership. And when scientists come to clinicians and say we want to do a study, we're aware that it's getting under people's feet and it's a pain, and not all LHNs and not all clinicians are prepared to take a chance and partner on these studies. And without those partnerships, the studies can't happen. So, a genuine thank you to you and your staff for being involved.
A pleasure. And to everyone today, Ananingi and Nakan, we will see you at our next grand round. Thank you.